Hey, good morning, everybody. Cool, we got a good amount of people this morning. I'll give just a minute or two for people to start trickling in. All right. Somebody give me a thumbs up if they can hear me okay. I just want to make sure before I start getting started.
We can hear you.
Beautiful. All right. All right. Good morning, everybody. Welcome. Thanks for coming by. For surely one of our favorite topics. And um, today we're going to be talking about refusals of transport and the kind of pearls and pitfalls that they're in. I think in general in EMS, we don't think about these calls too much. In general, when I am in charge of an EMS agency and I am providing medical direction, these are the calls that we probably think, you know, 180 degrees apart from each other a lot of times in, being on the ground when I've taken care of these calls versus when I'm, in this position now. So, these are the calls that keep me up at night. When folks don't go to the hospital, when we contact them and they don't go anywhere with us because we don't know what happens to them, right? Same thing when I'm working in the ER and somebody decides to go home instead of getting admitted to the hospital when I think they need to. I stay up at night wondering. So, I want to make sure that we're all on the same page of how we talk about and document these calls. One, to limit our own liability, but two, to hopefully kind of get the best outcome for the patient. Sometimes people really don't want to go to the hospital, and then you tell them some more stuff, and they're like, actually, that sounds like a great idea. I should probably go with you. So this is kind of a difficult hang on 1 second. I lost our window here. This is kind of a difficult topic to go through because there's a lot of different ways that people approach these calls. So I thought it would go through and get who's done? Oh, we're good. All right. Cool. All right. So I thought we would start off today with a case here. So this is a real case that happened. This was a case that an article was published about, so this is not any way related. This was in the early 2000s in Kansas. But it's an article I remember reading and I was like, oh my gosh, I can't believe, all this stuff. So I'm going to read this out to you guys, but the 68-year-old female was found in bed after adult children reported the patient fell on a kitchen floor. They picked her up and moved her to her bed. Daughter has durable power of attorney and states her mother suffers from Alzheimer's dementia with occasional paranoia and occasional hallucinations as a result. And her mom has had a prior stroke. On arrival, the patient refused exam or vital signs repeatedly. Only limited exam of her left hip allowed, and she was only complaining of left hip pain. They documented a full exam on this extremity, including pulse deficit, like no pulse deficit, normal neurologic function distal to the injury. She was not walking, but everything else was okay. The patient was able to remember the entire incident correctly, and they confirmed this by, the son was there and witnessed it. She stated her name correctly. She stated the president's name, her current location, and the year. She actually took 3 tries to state the year accurately. I changed the dates, but she went one too low, one too high, and then got it the third time. She refused treatment or transport. The crew on scene attempted to contact her primary care doctor, actually, but they were unable to do so. She was clearly able to state it is possible that she has a broken hip, nerve or vascular injury, or other injury that can't be diagnosed in the field. She's able to restate that these injuries will worsen, can worsen, and lead to permanent disability, such as inability to walk, loss of function or speech, or death. So she documented, or she was able to clearly state all of those things to the crew, and the crew documented exactly what she said. And then she signed a refusal of transport form. So this is her exam. She refused vital signs after multiple attempts. She was awake and alert, ANO times 4, 2-person, place, time, and situation. They put what she was oriented to specifically. She's moving all 4 extremities equally, refused auscultation, but they at least put that she looked okay, no diaphoresis or pallor. Pulmonary, no obvious respiratory distress, but she refused to have them listen to her. Refused exam. And then they noted that she was a little tender over her left hip, but it didn't look obviously broken. And she had sensation and motor function intact distally. So this is a patient with a history of Alzheimer's, does have a caregiver at home, but has a durable power of attorney in place, is refusing further assessment or transport, and can tell you she knows the risks. Who's transporting this patient? By show of hands. Or you can say it out loud if you're feeling brave. Who says we're leaving this patient at home? Anybody?
I would prefer to transport this patient. I would feel more comfortable given her mental issues, even though everything presents well. However, I would end up leaving her there because that's what she wants and she's got family support.
Yeah. So this is kind of the ultimate refusal call, right? This is a patient who has a court order in place saying that she can't take care of herself or her finances, and she has a durable power of attorney. Yet she's able to tell you every single risk. She's able to understand and repeat back the risks. And she really, really doesn't want to go to the hospital. So, and further complicating this, her kids are on scene and they're asking you to take her to the hospital. So, this is kind of the Mac Daddy of all, do we transport this patient or not? And this case actually had kind of an interesting outcome, so I will go through it at the end here, but keep this kind of case in mind when we're talking about all of these refusals of transport, because this is kind of the most complicated it gets. So if you can understand the outcome of this case, then you're pretty much good to go on everything else. So why do we care about this, right? Patients refuse transport all the time. Looking at our kind of caseload here, as well as previous systems I've worked at, people call EMS, just to get checked out, or I felt bad for a minute and I just wanted to make sure my blood pressure was okay, or, I feel fine now. I don't want to go. I'm worried about the cost, all of those things. In general, it's about 5 to 10% of transports nationwide. I think that number's actually gone up. We'll see in kind of the new iteration of these studies. But about 10% of the time, EMS gets to scene, provides care, and then the patient ultimately refuses transport. This is higher in certain contexts. So, for example, people that get Narcan, about 40% of those refuse transport. So, depending on the call, this can be a very common thing or not. Studies show that in high risk refusals, which we'll talk about, 30% have about no documentation about the patient's decision making capacity. So in our highest risk folks, about 30% of EMS charts nationwide on a random sampling appear to have no documentation that the patient had capacity to make that decision, which is, iffy. And the problem with all of these is that it's really difficult to balance the autonomy of the patient versus doing what's right for the patient, especially when these cases are pretty difficult. So, for example, one of the cases that I will always remember, when I worked in Dallas, I was on call and the medics called me from scene, and they had a gentleman who had fallen 3 times that day and was hypotensive. And this time he was on the floor. and he couldn't get up, and he refused everything except putting him back in his chair. And every time they went to sit him up, he would pass out. So he was in this endless loop of being so hypotensive that he was on the ground and couldn't get up. But then if he sat up, he would pass out. And they had to administer care and get him back down. And what was happening is that gentleman had capacity in those moments that he was awake, and then he would lose capacity as soon as we tried to move him. And that was really difficult to kind of manage. And ultimately, the gentleman got sicker and, ended up getting transported under implied consent because he was no longer conscious for a longer period of time. But it can be really, really difficult, tricky calls. And one of the things that I discussed with the crew so much is that if he's making the decision not to go and we're going to leave him on the floor, he's allowed to make that decision. But you have to document very, very clearly if he has the capacity to make that decision. So there are 4 criteria for refusal of transport, and these have to be met on every single refusal. There's quite a few kind of articles that go over this, and I can put those links to those in the comments at the end. But in general, they're understanding, appreciation, reasoning, and then the expression of the choice. So let's go through those. Understanding, these are all kind of pretty self-explanatory, but I want to make sure we're on the same page. So understanding the individual ability to comprehend information being presented. Does that person actually understand what you are saying and what you are telling them is happening? So they understand their condition and the risks and benefits of not being treated. So, for example, if you get called to a kiddo with a fever, this is not a real quote, it's just something I made up, but so if mom looks back at you and says, I understand my 1-week-old has a fever and is not acting totally normal, that's why I called, but don't kids just get fevers? Isn't that a normal thing? We don't have time to go to the hospital. She has a doctor's appointment in 2 weeks. She'll be fine. I don't think this kid needs to go to the hospital. What you're saying to that patient is, this is a 1-week-old with a fever. 1-week-olds with fevers are a really big deal. There's like a 50-50 chance that they're septic, just so you know, which is why we treat them very seriously. On these kids, we get lumbar punctures, we get blood work, we get cultures, we admit them to the hospital on antibiotics, no matter what those results say, and we watch them. Because there's a 50% chance that they're septic and could die. So this mom, when you're saying, hey, your 1-week-old has a fever, that's a big deal, they need to go to the hospital, she's clearly not understanding how big of a deal that is. She thinks, oh, kids get fevers. So this is an example of a patient that's not quite there with the understanding part and probably doesn't have enough information to be able to refuse yet. The next step is appreciation. This feels like the stages of grieving or like a 12-step program, but it's a little bit different. So appreciation is that they can actually apply the info that they're being presented to their situation. So, for example, this is somebody that has good appreciation for their situation. Somebody that suddenly had right-sided weakness, they can say, I understand my right-sided weakness means I could be having a stroke. I understand that I might not be able to walk, write, or work using my hands again without treatment. And I still don't want to go to the hospital. That person can tell you all of the things that might happen to them, and they understand that they're probably having a stroke and that might affect them for forever. But they know exactly what's going on. So they have the ability to refuse based on that statement. Now, their reasoning for why they don't want to go has to make a little bit of sense too. So if they are saying, yes, I understand something's happening to me and I don't want to go to the hospital, and their reasoning for why they don't want to go to the hospital is totally out of left field, then that's not great for refusal either. They might need some further evaluation of their capacity. So for example, someone says, my chest pain could represent a heart attack. I know that could kill me. So they understand the stakes, right? And they understand that they might be having a heart attack. But I'm not worried because I'm simply possessed by an evil spirit that I can expel at any moment to cure myself. The real thing that a patient's have to be. So that doesn't make any sense at all, right? That person doesn't have intact reasoning for why they don't want to go to the hospital. So that person probably is a hint that they don't have capacity to make this decision right now. And then finally, the expression of choice. So this is very common in most often you'll see this really highlighted in cases that include end of life care. And their choice has to be kind of consistent across their stated wishes. So they have to be able to communicate their decision in a manner that is clear and consistent. So, for example, I understand that I could get worse or die, but I never wanted to die in the hospital, and I know I don't have long to live regardless, so I want to stay at home no matter what. In patients that are getting hospice care, this is very common, or in patients with a terminal diagnosis, they just don't want to die in the hospital, and they understand that that's, a strong possibility for them. So they'd rather just stay home, especially in hospice or otherwise end of life patients. They'll usually have some sort of documentation or a family member or somebody that said, yeah, they've always said they don't want to die in the hospital. They've always, this makes sense. This is not something suddenly new for them. Same thing if you approach a patient who was saying, I want to go, I want to go, I want to go, and then all of a sudden changes their mind. That's worth digging into a little bit more because the lack of consistency throughout their time and being evaluated is a little bit concerning that there might be something else going on underneath the surface versus just, I don't want to go to the hospital. Questions on those things? Cool. All right. So one thing that comes up quite frequently in these calls is we have to make sure that folks have capacity to make their decisions. I've already said that word a few times, and I'm going to say it about 16 more. So be ready. But the distinction comes between capacity versus competence. These are used interchangeably in a lot of scenarios and just the English language in general. But in our context, in EMS and in medical care and in legal situations, they are absolutely not interchangeable and they mean very different things. So let's get really clear on this. In general, I think we do this very well based on looking at our charts, but I just want to make sure that this is kind of the same baseline. So capacity is a fluctuant state of being able to consent to treatment. It changes minute to minute, sometimes second to second. It has nothing to do with the courts. It is all based on our evaluation as medical providers. And then competence is court ordered. So, for example, in that first case, that patient had Alzheimer's, that patient had hallucinations, and they had a durable power of attorney. That means that a court has ordered that they are not competent to make their own life decisions. Usually, this is a financial thing or somebody who's gravely disabled due to some underlying intellectual disability or mental health condition. But just because they have a order that they are not competent from a judge does not mean that they don't have capacity to refuse treatment. These are two completely separate and non-interdependent things. So capacity is always assessed at the time of the encounter. If you got there 5 minutes ago, they might not have had capacity. If you got there 5 minutes later, they still might not. But if you're talking to them right now and they meet capacity criteria, then you're good. It's determined by the healthcare professional. It fluctuates constantly, and if they do not have capacity, if you judge them to not have capacity, then they have the next person in line to make a decision for them is their medical power of attorney. And we'll go through the list of, who it goes from there. But if they have a listed medical power of attorney, that person is now making their medical decisions for them. They don't get to make any other decisions other than the medical decisions. Competence has to be court ordered by a judge. So there needs to be documentation and they need to have gone to court or appeared before a judge at some point, and that judge has appointed them a legal guardian. Now, that might be someone that they don't know appointed by the state if they don't have any relatives that are able to do it, or it might be a relative. Like in our first case, it was the daughter. It does not determine if capacity exists. So capacity has to be evaluated separately. For example, if somebody has a court order, that does not mean that they never have capacity again to consent to medical treatment. And if they're not competent, then they will have a durable power of attorney. Now, durable power of attorney allows you to make financial decisions for the patient. It allows you pretty much access to all of their assets. So, for example, if you're the durable power of attorney for your grandmother who has Alzheimer's and needs to go into a memory care facility, then as the durable power of attorney, you have the option of selling the home that she lives in to be able to pay for the memory care facility full time. So you have access to their financial means and access to the other things and decisions that adults have to make in their lives. Sometimes that includes medical power of attorney, sometimes it doesn't. So you have to distinguish those two together. Questions on that? Okay. In general, I think those are very well understood here, but so we only ever determine capacity. We will never determine someone's competence. You can think of it like competence is, when someone says they're competent to stand trial after they're going by, a not guilty for reason of mental illness kind of plea, then they're determining competence to stand trial. So it's associated with the legal aspect of things, whereas we make decision-making capacity judgments. So if your patient does not have capacity, now what do you do? So in the state of Washington, this is our list. It's a little bit longer than other states if you ever have practice elsewhere or go outside of the state. But number one, whoever has the paperwork. So legal guardian, whether that's medical power of attorney or durable power of attorney, go to that person first. And you want to make sure that the durable power of attorney is also the medical power of attorney and the patient didn't sign paperwork to split those two at one point. The DPOA or the MPOA should be able to tell you that. Next, you go to spouse or state registered domestic partner. If they're not married, then as long as they're registered with the state as domestic partners, then they can make decisions. Boyfriend, girlfriend do not count unless they are actually registered with the state. Adult children, there has to be a consensus among the adult children. Parents are the next step after adult children, and then adult siblings are after that. So if you cannot contact any of those people in the field, you go with whoever you have ability to contact. A lot of times that's going to be siblings or one of the children or anything. And then once they get to the hospital, we can figure all the rest of that out. And frequently it doesn't even get figured out until they're already admitted to the hospital, sometimes for a couple of days. So just whoever you have on scene that you can contact and, reliably tell that they are the decision maker for the patient, that's who you have to go with. In Washington, we can actually talk to adult grandchildren as long as they're familiar with the patient. If they've never met, they can't make a decision. Nieces and nephews who are familiar with the patient, aunts and uncles who are familiar. So basically any family relation, as long as they can establish that they have some sort of relationship and they've talked about this stuff before, they can take care of, or they can make medical decisions. And even in Washington State, under certain circumstances, an adult who's a close friend can actually make decisions for the patient. There's very specific criteria that they have to meet for this. So this should never be your first choice if you can avoid it. But, a lot of folks that I've taken care of here have a very close neighbor that they eat every single meal with, and they spend every day all together, and they know them better than anybody. They're not related, so there's no legal relationship there. But they may meet criteria to make medical decisions for that patient in the right circumstances. So what if your patient's a minor? Unless they're an emancipated minor in the state of Washington, they need somebody to provide consent for them. They, by definition, don't have decision-making capacity, in other words. There are some exceptions to that. So here, if they are married, even if they're under the age of 18, they're considered emancipated. If they are pregnant and under the age of 18 and they're seeking pregnancy or STI-related care, then they can consent to their own treatment. They don't need other adult consent if they're pregnant and seeking pregnancy-related care. If they are in the military under 18, I don't know how that still happens, but if that's the case, then then they are able to consent for their own care. If they are a teenager, if they're 14 and up, some of these conditions go down to 12 and up. So it's worth going back through the list. If you give it a Google, it's pretty easy to find. And I can attach the list after this. But if they are a teenager, usually 14 and up, seeking treatment for mental health care issues or substance abuse issues, then they can consent to their own treatment for those things. So they can't consent to their own treatment for other things, but specifically to get mental health care or for substance abuse issues, they can consent to their own treatment in those cases. So if you see a 15-year-old that calls and has a fentanyl overdose, and when they wake up, they're scared, they want to go to the hospital, they're, talking about maybe I need to go to rehab, that's okay. You don't necessarily have to immediately call their parents and ask if it's okay for them to be transported. They can actually consent to their own. And we'll talk to the patient because there is some statute in Washington that if the minor requests that their parents not be contacted, that you can actually honor that request. So in certain situations, you actually don't want to contact the parents if the patient specifically requests it. And it's typically those mental health or substance use issue related care. Now, people can act in loco parentis. So the most common is parents are out of town and they left them with aunt and uncle. Aunt and uncle can consent for the patient, or when they're in school. So this is always the kind of famed nightmare scenario is like a school bus crashes and none of the parents are around. The school administrator should be contacted or show up. Excuse me. And they should be able to consent for treatment and transport of the patients until the parents can be notified and contacted. Teachers can also do this. Other relatives can do this, as long as it's clear that they were left in charge of the patient. Now, if your patient is a minor and the parents are refusing medical treatment for what you deem to be a potentially emergent or life-threatening situation, then that is something that you need to contact law enforcement and safely transport that child to the hospital. Parents are not allowed legally to refuse life-saving treatment for their minor child. So, if you have a child that you are very concerned has meningitis, they are not moving their neck, they have a high fever, they're vomiting, they look terrible. Regardless of whether or not that child ends up having meningitis, if you think this kid read the textbook for meningitis and they look really bad and they look septic and they need to go to the hospital and the parents refuse, then that becomes our responsibility to get that patient to the hospital. And a lot of times law enforcement has to be involved in these cases. I don't think they're super, super common around here, but I'm sure all of you have at least heard of or been involved in one of these. They're really difficult, but it is our responsibility as the health providers to actually make sure that that child gets care regardless of their parents' consent, because at that point, that's endangering the life of a child. Now, we're going to talk a little bit more about capacity and kind of these situations where it's a little bit difficult to assess. So for psychiatric emergencies, we touched on this a little bit before, but again, having a mental health disorder does not mean a patient that does not have capacity for the rest of their life. The one exception is anytime somebody says they have suicidal ideation, especially when they have a plan to harm themselves or have actually made moves to harm themselves. So for example, a 16-year-old that has suicidal ideation and has been diverting some of grandma's heart medication for the last month, and when you show up on scene has a stockpile sitting there, but they called and someone requested help for them and they say, well, yes, I'm thinking about committing suicide and I have made plans to do it, but I haven't done it. That is a very high risk patient. By definition, suicidal ideation knocks off that reasoning portion of why they don't want to go to the hospital. So they need to be transported regardless of the rest of their decision-making capacity. Very frequently, suicidal patients will meet all of the criteria for they understand their situation, they understand the risks, all of those things, and they're normally not having active, hallucinations or delusions, anything like that. They can reasonably speak with you and discuss all of these things, but having suicidal ideation, especially with a plan, makes them high risk and they don't get that point of reasoning in those four criteria. So when you're assessing somebody outside of the, realm of suicidal ideation for another mental health complaint, you should ask about paranoia symptoms. Most people who have had mental health treatment previously, even if they're not currently in it, know that paranoia is a thing that comes with a lot of mental health disorders. So you can ask straight up, have you been feeling more paranoid? Do you feel like people are following you, watching you, those kind of things? And then auditory or visual hallucinations. The way that I ask this is in the past few days or weeks, have you noticed that you're seeing things that other people can't seem to see, or you're hearing things that other people aren't hearing? Because sometimes they won't automatically, especially if they're in a crisis, recognize that those are not real, that those are hallucinations, auditory or visual. But they will notice that other people don't seem to be reacting to the things that they're seeing and hearing. So that's usually how I would phrase that question. And then suicidal ideation or homicidal ideation. Those are the two that we're very used to. The case laws regarding this of when you have to transport these patients versus when you can leave them alone is very vague, unfortunately. So this is not a place where we've had a lot of cases go to trial and we have established a law on what is, and is not hard criteria for this, which is why this is so hard, right? Because if there were checkbox criteria, then we would be totally set and we wouldn't need these kind of talks. But of the case law that we do have, phrases are included, such as this person is an immediate substantial threat to themselves or others. Even if they're not suicidal, if they're having delusions or hallucinations that cause them to run out into the middle of the highway into oncoming traffic, they're an immediate threat to themselves or others, and they need to go to the hospital, even if they're not trying to harm themselves or other people. So it leaves a little bit of wiggle room to just allow you to make that judgment call, but ultimately it is a judgment call in this case. You can enlist law enforcement for temporary peace officer detention. They can put people under an ITA and get them to the hospital. Or a lot of you now have access to a DCR that you can dispatch in the field to make these kind of recommendations if they're available. That's a really good option because that allows them to be placed on a hold so that when the police bring folks in without a DCR, they're technically not on a hold until they're evaluated by a DCR. They're on kind of a gray zone pre-hold where the ER doctor or anybody at any point can kind of say, yeah, I don't think they actually need to be here. But so it's a little bit of a gray zone, whereas the DCR hold is much more concrete. So if that's an option that you have access to, then that's probably your best option if you're able to do it quickly and safely. Intoxicated patients are another area where we get into some kind of confusing situations. The use of the substance does not immediately take away somebody's capacity. And ultimately, you gotta eyeball these a little bit, right? So clinical intoxication is the best measure of whether or not somebody has capacity. So if you're just looking at someone and they look like they've been drinking all day, they look disheveled, they smell like alcohol very strongly, and they're acting intoxicated, they're slurring their words, they're staggering around, then that person probably doesn't have decision-making capacity. If you run into someone who, was at the bar and they were sitting back too far and they fell off their bar stool backwards, they hit their head, they feel fine and they're refusing, and the bartender is able to tell you, yeah, they just had one beer and they're not clinically intoxicated appearing. Like you wouldn't see this person on the street and go, yeah, they're drunk. Then they actually have capacity. So this is more of a clinical assessment than anything. If they look intoxicated and you're not sure, then the answer should be get them to the hospital. The caveat here is you have to get them there safely. So no court or lawyer will be able to protect you if you take an intoxicated person and restrain them in a way that causes them to asphyxiate or gets them uh, causes further harm than good on their way to the hospital. So you have to safely restrain the patient. You have to make sure that they are continuously monitored with all of your monitoring, your cardiac monitors, your pulse oximetry, your end-tidal CO2, if you have it available, is a great thing to put on these patients. And then you need to provide them any chemical sedation that you need to, so that they're not constantly fighting those restraints the whole time and causing further damage. But if you're going to make that decision, you need to continuously monitor them the entire way to the hospital. People have gotten in trouble in the past in other parts of the country for restraining people and then not putting any monitoring devices on an intoxicated patient. And they can get much worse very quickly, especially if they're very intoxicated. So that's something that you really need to be careful of. Now, the trouble with this is where we usually run into issues is when somebody is a chronic alcohol user. So they drink a little bit to a lot every single day. Now, some of these folks actually have drank so much and they have such a tolerance that when they are sober, they do not have capacity because they have withdrawals and they have hallucinations and those things that come with them. So just because somebody is drinking, they might actually have better ability to consent and better capacity assessment when they are drinking than when they are sober. So if you run into somebody who is a chronic alcohol user who does not appear intoxicated but seems to have been drinking that day, then they might actually be able to pass a capacity assessment. That's really the one that kind of gets folks. But the only person that this will happen in is somebody who drinks a lot every day, like somebody who drinks a fifth of vodka every day. That person, their baseline is being intoxicated. So they might look and function totally normally at that level of blood alcohol that the rest of us would be stumbling around. So that's kind of where the clinical assessment piece comes in. This is always a little bit more of a point of contention when we're making these assessments. So does somebody have questions about that before we move on? Okay. Not hearing any. We'll keep going. So transient lack of capacity, I think we're all familiar with this. I think the most common way that we encounter this is when we have somebody that gets Narcan. So when you show up, the person is completely incapacitated. They are unconscious. They might not be breathing. They might have gotten CPR briefly. And then you treat the underlying condition, and then they're totally back to normal. And they're refusing treatment and transport. Like I mentioned earlier, folks that get Narcan, this is 40% of those patients will refuse transport or will just get up and leave the scene. It is not your responsibility to chase those people down because you saw them not have capacity and then regain capacity. It is okay once they have capacity that they are able to refuse. However, they should be able to articulate those 4 points that we mentioned earlier. So they should be able to tell you, yes, I understand that I could, this Narcan could wear off and I could get worse again. No, I don't want to go to the hospital. The other time that we see this is hypoglycemia. So folks that are very hypoglycemic and unconscious or very confused, we give them some D10, we get some glucose in them by whatever means, and then they pop right back up. Um, and they understand that, they have a risk of this recurring and they don't want to go to the hospital, then that's okay. But again, they should be able to articulate those points. If this happens sometimes, if your patient loses capacity again in front of you, like they got Narcan, you've been sitting on scene for a while, the Narcan wears off, and you witness them go unconscious again, then you can still transport that patient under implied consent, provided that they don't have capacity at that time. So just because they said they didn't want to go at one point doesn't mean that you can't now transport under implied consent. So the other kind of last thing that gets a little bit hairy is when folks have some sort of neurocognitive disorder, whether it's an intellectual disability that they were born with, or whether this is a developmental problem, or whether this is a problem associated with aging, like Alzheimer's, dementia, or vascular dementia, prior stroke, any of those things. So it's most prevalent in the elderly population, but it does not preclude capacity. So there's two things that could be going on with these patients. One thing that we see very frequently in older folks is delirium specifically. So just like capacity is a temporary state, whereas competency is a permanent ruling, delirium is a temporary state of confusion that is waxing and waning by definition. And dementia is a permanent condition. Sometimes people are a little worse off than other times during the day when they have dementia, but they never don't have dementia again. So delirium is very highly associated with older folks that get any sort of other illness. We're all probably very familiar with our 80-something-year-old women that get a UTI and get temporarily confused. And they may look like they have dementia all of a sudden, but then as soon as we get them treated up, they are totally fine and back to functioning completely normally. That's delirium. So somebody may lose capacity when they have an illness, even though they don't have dementia, because they are delirious in relation to that illness. Dementia is a permanent neurocognitive disorder. So once you have it, you have it. It's not going away until somebody finds a cure for these things. These folks can still have capacity because some days are better than others and some times of day are better than others for folks with dementia. But they need to be able to pass that capacity assessment. The main reason or the main thing where this comes up is the lift assist call. The lift assist call is very common, but it is fraught with issues related to this talk. If the patient does not have capacity when you show up, they're not able to tell you the risks, they're not able to express that they don't want to go to the hospital, all those things like we talked about, and they don't have a pulse that is there that says never transport this patient to the hospital very specifically, then you need to contact their medical power of attorney or their next of kin, or you just need to transport them like you would anybody else that doesn't have capacity. Now, I'm not a fan of practicing medicine to legal standards, right? We ultimately want to practice medicine based on medical evidence of what works best for the patients and also respecting the patients and their decision-making abilities. But this is kind of an area where, kind of regardless, we're providing good medical care, but there's some legal considerations to be undertaken here. Now, in general, these kind of align with what I would suggest is probably the best medical practice anyways. So in general, in the case law that does exist for cases that relate to either transporting a patient against their will, and they argue that that's kidnapping, versus honoring somebody's request to stay on scene, and there's a question of whether or not they had the ability to make that choice after something bad happens. In general, when these cases go to court, they tend to favor healthcare providers. Number one, in general, healthcare providers in general, whether they're doctors, nurses, EMS, tend to do well in court. So This is not something to lose sleep over. But that's because we have evidence and documentation on our side in those cases. Courts tend to favor healthcare providers when they document their capacity determination well. So when they cover those 4 points, they don't have to be explicitly written out, but when they say something to each of those 4 points, and when they appear to act in good faith for the best interest of the patient. So if you get up, God forbid a case of yours ever goes to court and you get called onto the stand and you say, this patient looked very, very sick. They didn't appear to have capacity based on the things that I wrote in my chart. And I felt that the best possible thing that I could do for the patient to ensure that they're surviving and thriving through the remainder of their life was to get them to medical care. Even if they come back later and say, I didn't want to go, they kidnapped me, you're going to be just fine. Courts tend to rule against providers when it's really unclear what was going on scene. So if there's nothing written in the narrative regarding the patient's decision-making capacity, and then they refuse transport, and then they, show up a few hours later as a CPR call, then that's not going to look great. If the care doesn't seem benevolent to the patient, even if you did everything technically right, and you document something to the effect of that sounds kind of callous or uncaring in the chart, which sometimes we do because our jobs are hard and we work long days and all those things. The courts don't like that. And the people that are reading these documents are people that don't do your job, are people that have a regular 9 to 5 where they don't get yelled at and they don't get things thrown at them and all those things. So they don't have that context to understand why those comments might sneak in there. And thankfully, these are very rare. But there have been cases that have gone to court in the past few years where they put that EMS documentation up and they're like, it's really hard to overcome that if you document something that sounds less than favorable to the patient. Okay. Not all refusals are created equal here. So low risk refusals, we don't tend to worry about as much. They should still meet all those criteria and they should still have decision-making capacity, but they're kind of low stakes, right? So you cut your finger when you were washing dishes with a kitchen knife. It's a tiny cut. That's fine. Throw a bandage on it. You can stay at home. Fine. So low risk, I would define as low acuity calls. The patient is well appearing. They're otherwise healthy. They're an adult or, a child that's over the age of 2, usually. The really little ones we get worried about. And they have a very low likelihood of dying from the condition that they called for. So small lacerations, ankle sprains, flu-like symptoms that are not meeting sepsis criteria, all of those things are totally fine. High risk is anything else we just talked about. So any of those people with mental health disorders underlying, any people with dementia, any people who have an emergent medical condition that you think is actually potentially life-threatening, those are all higher risk refusals, and those are the ones that I want you to be really careful about. So all these PCRs, no matter what you're seeing, even if they get transported, need to establish 4 elements here. They need to establish that you, as the provider on scene, are aware of the actual circumstances underlying the call. So, for example, if the call is for chest pain, you need to write the word chest pain in your chart, and you should probably get an EKG at some point. The assessment and findings. So you need to document that you actually examined the patient, looked at the patient, and what you saw. You need to establish whether associated policies, procedures, and protocols were followed. So this is just typically what we do in terms of documenting our care. As long as you don't do something that's really out of place, then you're probably going to cover that. And they need to establish that appropriate treatment was delivered. Now, a lot of times when I talk about this topic, this is kind of what's brought up, is we have a refusal form. The patients sign the refusal form. Why is that not enough to protect us? Like, why do we have to write anything at all? We made up this refusal form specifically for this purpose. Now, this is the tricky part, right? This is a made up thing from a lawyer that also works EMS. There's a big law firm that does EMS law throughout the country. And this is a blog post that the lawyer did of kind of, cases that he's seen previously that go to court and vaguely, made up dialogue, not from a real case. But basically, the point is that if a patient gets up on the stand and says, well, I just signed it, I didn't read it, or it had a bunch of jargon in it that I didn't really understand, and they just said I had to sign it if I wanted to stay home, or I didn't have my glasses, I don't know what it said. That's pretty easy to throw out in court. And especially if, there's no documentation that you actually had a conversation with the patient, it just says refusal form signed, then that's really not protecting you nearly as much as you think, because it's pretty easy to get in front of a judge and say, well, I felt terrible, I didn't read it, and they didn't tell me anything. So that's not as protective as we would hope or really think. There was an actual case like this that was a successful lawsuit against the EMS agency. Yeah, even if it's witnessed. Because who knows if the witness really read it either. And I don't know if you've read through our form, but our other agencies' forms, but they can be kind of long and they're full of a lot of legal jargon. So if you have somebody that questionably has capacity and they're refusing, then, they might not have the vocabulary to be able to interpret that form. They're not exactly written in plain language. So even if it's witnessed, you still have to document that you had the conversation with the patient and that they were able to tell you. And then that refusal form has a little bit more weight because now you're signing on the chart that says you had that conversation. Cool. Sweet. All right. So this was a real case long time ago. But this is all public record, but this is the narrative. This is a 57-year-old Caucasian female seated on the couch. Vomitus on the floor. She had eaten a burger from Burger King about an hour before going on a walk. Had no chest pain, denied any medical history, which turned out to be untrue. Just the patient said she didn't have anything, but she had a lot of heart history. Stated that when she returned to the house, she got dizzy, lightheaded, and nauseated. He assisted her to the floor in the kitchen. Her skin was cool and diaphoretic. She was A&O times 3. She said she felt fine after vomiting. It was in Louisiana. It was hot outside. She said she was maybe just feeling the heat. Blood pressure was taken, and it was low. The patient again said she felt fine and refused transport to the hospital for the evaluation. She refused all transport attempts. She repeatedly said she didn't want to go. She signed the form, but later that day, a few hours later, she got family called back and she was a CPR and ultimately had a STEMI, did not survive. This crew, in this case, did not get an EKG. They had a written form for refusal of transport, so they had a piece of paper. All these cases were like 20 years ago because they take so long to go through the courts. They didn't fill in any of the form. So there was a specific thing that said risks and there was a bunch of blanks, and they didn't write anything there. They just had the patient sign it. And it was witnessed by the patient's husband, but there wasn't anything written on the form about specific risks. And the form said up to and including death, but they didn't write anything under the specific risks for this patient. And there was no documentation. This was the entire narrative. This was the entire chart. There was no documentation of, we discussed that you could be sick. If you stay home, you could have a heart attack and die. You could, pass out again. You could feel worse and call back if you need us. There was no documentation of any of that conversation. So ultimately, this went to court and the EMS on scene was found liable for this refusal and the ultimate outcome of the patient. So This is something that is kind of pretty typical, but this is actually something that would be difficult to defend in court and was unsuccessfully defended in this case. So what I want you to do is treat these high risk refusals as though they are procedure. So we have procedure protocols in our sets of protocols. One of the things that you will notice with our new set of protocols here in that hopefully all of you have kind of started looking over or are getting yourselves very familiar with that will start on December 1st is that we have a very extensive protocol for refusal of transport now. And it includes all of these things that we just went through written out. So if you treat it like a procedure and you go through point by point what you need, and then you write down, you document just like you would a procedure, specific points, then you'll be just fine no matter what. So certain agencies, this is that same law firm that does EMS law, they have a checklist that's made by lawyers, so it's not super great for the field. But if you want an idea of like a straight up checklist, then this is one that you can use. And I'll put this link in the notes when we post this. This is our checklist. So we have an actual refusal checklist. You can go through point by point. You can, collect the demographics, get the history, make sure that there's no scary elements in the history like in here. You can, gather the medications, any special considerations like the ones that we already talked about. And then those specific things like history of mental health problems, dementia, intoxication, all of those things that I talked about, all those points are written out in this checklist. I just didn't put them all on here because we already talked about them. So you can review this at the point of service. Exam, it has points for all of those things that will help you document a good exam. You assess the patient, you provide them with their clinical recommendation, and then you go through those 4 points that we talked about, the understanding, appreciation, reasoning, and then you have to communicate that, you should call back and all those things if that's the case. So this is a very good straight up checklist that is, created by our protocol committee to protect you as much as possible. If you don't like checklists and you prefer a mnemonic, this is your mnemonic. I'm not a mnemonic gal, but here we are. But cured, so they have capacity, they have understanding, you've talked about the risks, you've educated them on what to do if it gets worse, and call back or go to the hospital or go see your regular doctor tomorrow. And then you documented the heck out of all of those things. I know we're running out of time, so I'm going to speed through this a little bit, but this is kind of the documentation bit. It'll just be a couple minutes here, okay? So documentation wise, these are the things we specifically want from you. And again, this is in the checklist, but you want to discuss any special considerations. So this is a hospice patient. This is an intoxicated patient. This patient transiently had capacity and then lost it or gained it after you got on scene. Discuss all of those things in your chart so that they are highlighted and they are obvious. If they're obvious and they're addressed, then they're no longer major issues. And then describe your findings related to those. For example, this guy drank a couple of beers today, but clinically he doesn't appear intoxicated. He's able to answer all the capacity questions, and he does not appear to have a life-threatening injury. So he can refuse. Describe any abnormal findings on your vital signs or your exam, and then write out your capacity determination and your reasoning. You can use quotes for the patient, but they should be accurate. So don't paraphrase. Make sure that they're exact. Because if anybody ever looks at that chart and they're paraphrased, then that's, potentially concerning to other parties that might look at our charts. Include other parties on scene. So if the medical power of attorney is there or the patient's husband is there, like that last case, put that you spoke with the patient and the husband and they both agreed not to go to the hospital or something to that effect so that they know that there's other people on scene that are kind of mitigating these issues. And then I highly, highly encourage you, if you have a high-risk patient with a potential life-threatening illness, to call medical control. Ask for the star doc. Don't just stop at the NTL. And if they're really high risk, put them on the phone with the doctor. If one of us is on, myself, Dr. McNeely, or Dr. Wyke, we'll take the call and we will gladly sit on the phone and talk with the patient. There's some evidence behind this that actually, if you put them on the phone with the doctor, just for whatever reason, saying, I'm Dr. So and so, makes the patient about 70% of the time when they refuse for high risk, will go to the hospital after that. So if you're really worried about somebody, you got a 70% chance that they'll change their mind and go with you if you put them on the phone with the doctor. So it's definitely worth doing if you're worried about somebody. And then try to include the name of the doctor that you talk to, because not everybody that would read our chart knows what a star doc is, or if you type medical control, it's not clear if you talk to a nurse or the doctor. So just write doctor at least, or Dr. So-and-so if you can get their name. And then talk about the outcome in detail. They declined treatment or transport, and you counseled them on blah, blah, blah. In terms of vital signs, you need at least one full set, preferably if the patient will allow you, and you've been on scene for a little while because you're talking about all this stuff, get a second set so you can get a trend. A single point in time doesn't really tell us anything, but a trend tells us a lot more information. And then a detailed physical exam. You want to support yourself on your suspected diagnosis as much as you possibly can. And really, 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 the thing that helps prove that you had the best interest in mind for this patient, you wanted to take the best care of them possible, is that you counseled the patient. And that didn't happen unless you wrote that it happened. So it doesn't have to be long and extensive, but you can say, you know, you are welcome to call back. You can call 911 and we will come reassess you at any point. If you change your mind and you want to go to the hospital, you're welcome to have someone drive you, or preferably if you're really sick, call us back and we will take you at any time. This is not a refusal forever, it's a refusal for now. And you should say, listen, if you don't want to go with us, we still think you should go to the ER. You should have somebody drive you. Don't drive yourself. Or if you don't want to go to the ER, you should call your regular doctor and see them as soon as possible and call us back if anything changes. Just putting that in the chart saying I discussed these things with the patient is very, very legally protective, and it makes it look like, and have the appearance that you had the patient's best interest in mind. We all know that you do, but when other people that do not work in this line of work are reading our charts, that's not always obvious to them. There's an example of a really good documentation of this. I'm going to skip over this and you can read it in other things just for time. But again, if this is a high-risk patient, we completely trust you to understand and know that these patients are high risk and to, make that capacity determination. But if you're ever concerned about a patient that's high risk and they appear to have capacity and they're still refusing, then it's worth the couple extra minutes to just call and get a doctor on the phone to talk to them, because there's a good chance they'll change their mind, and then we can all sleep better at night knowing that they got the care that they ultimately needed. Now I want to skip back because I don't want to leave you hanging. The case that we talked about at the very beginning, lady with Alzheimer's, fell, possibly broke her hip, refused everything. And we talked about the documentation. This is the outcome of that case. So the crew on scene tried to call the primary care doctor. Nobody answered, of course. They contacted their online medical control, who said the patient cannot be transported against their will. So they documented a doctor's name saying, yeah, it sounds like they can't go, and the patient still refused. The police was called to the scene by the family, and the police assessed the patient. They actually knew the patient previously. They had contacted her before, and they refused to place the patient in protective custody as the officer was familiar and said she's at her baseline mental status. So even the police said that she couldn't be transported against her will, despite the family wanting her to be transported. The crew on scene spent over an hour trying to convince this lady to go to the hospital. And obviously it didn't work. She got seen by her primary care doctor the next day, and they found a hip fracture. She was admitted to the hospital, but she refused surgery. She refused supplemental oxygen. She refused monitoring. She developed pneumonia And ultimately, she got discharged home on hospice and passed away a few days later. Now, this family filed a complaint with the Board of EMS. This was in Kansas. They were found to have no fault due to thorough documentation that the patient had capacity. So that complaint was thrown out. They referenced protocols heavily and found that the crew that had no discretion to transport the patient against their will, and that was so well documented that they had no question at all that this crew did the right thing. They filed a lawsuit, both a civil and a criminal lawsuit, and both of those immediately were also thrown out. They didn't even hear the criminal lawsuit because they were found to have no standing. And then the civil lawsuit found, again, per protocol, patient received appropriate care, and it would have been actually considered kidnapping if they had transported this patient against her will due to their protocols and their state laws. So this is really an attestation that, even in these extreme cases, if you document well, if you cover all your bases and you really try to do the best thing for the patient, but you ultimately respect their wishes, that you will be protected and you will end up in a safe spot. Okay. I have some examples at the end here. I'm going to skip those because I'm already running a little bit over. I will stick around for a couple more minutes if anybody has any questions that they want to talk about. But otherwise, thank you all so much for coming, and I hope this was useful. We'll put this recording up on Rescue Hub along with the PowerPoint slides that I'll send out. And I'll see you around next time.